But you know what that also means? 10% have not. 10%. They were detoxed in a week. A year later, they're still clean. 10%. Now, my hypothesis, I haven't studied this, but my hypothesis is that these 10% are populating the 12-step rooms. They're working a good program, but they're also telling the people in the 90%, you shouldn't be on Suboxone. You're not clean. I didn't have to stay on it, so why should you? We have the same illness. Opiate dependence, opiate dependence. Now, haven't I taught you so far how that is just a naive view? Resiliency versus vulnerability, right? You saw the adolescent with the perfect cognitive function, inhaling 2 cans of hairspray a day. Would you think in a second to recommend to your 17-year-old girl, go ahead, do it, enjoy. It's not going to have any problem. She didn't have any problem, so why should you? You see how foolish that sounds? Because we all have different degrees of vulnerability and different degrees of resiliency. Those people in the 10% who manage to stay clean after a year, extremely resilient brains. We see that too in our program, right? I don't keep everybody on Suboxone for the same length of time. In fact, no 2 people are ever on it for the same length of time. How long? Studies are ongoing, so we have to wait to know what the studies tell us. But what do we do with the patient today, since we don't have the studies? Well, you've learned what healthy brain function is. You've learned about the different parts of the brain. I've told you that the opiate system is involved in many of those parts of the brain. Right? Judgment, executive function, mood regulation, impulse control, anxiety tolerance, the motivation reward system. Opiate system is involved in all of these functions. So, is it reasonable to think that if we have a working natural opiate system in the brain, then the brain may no longer need the Suboxone to provide that opiate function? Just a hypothesis. How do we know that the person has a working opiate system in the brain? Well, let's look at the closest thing we can without doing a brain biopsy. Let's look at brain function. Let's look at the individual. Is the individual regulating his mood, tolerating anxiety, making healthy choices, working a strong recovery program, attending meetings, working with the sponsor, getting a job, taking on responsibility, fulfilling obligations? You can't do any of that without a healthy brain. If a person is doing all of that, that person has a healthy brain. That's great. Now's the time. Let's start slowly decreasing the Suboxone and watch the function. Do we see any impairment whatsoever? Do we see an unhealthy choice? Do we see any evidence of increased impulsivity, poor mood regulation, that kind of thing? Uh-oh, slow down. Don't decrease for a while. In fact, if we don't see any improvement with all of our other psychosocial interventions, then we better increase it a little bit. The brain told us, you went too fast. Try it again. Decrease again. Decrease again. Now, maybe the brain is so resilient, you get through that process in 4 weeks, maybe 6 weeks, maybe 8, maybe a year. We have someone right now in the PHP, actually, came in with opioid dependence, heroin, 10 bags a day. Began to experience significant withdrawal. I talked with him about Suboxone. He was familiar with it. He thought it would be a good idea. He said, how long do I have to stay on it? I said, I don't know. We'll learn together. Started it, suppressed all of the withdrawal. Felt thankful about that. And now he's exhibiting already in PHP. A pretty healthy brain. Resiliency. He was physiologically dependent on the opioids, but he probably didn't experience the same degree of toxic effects on brain function. His impulse control is very healthy. His mood is well regulated. He's tolerating stress. And I stress him, right? That treadmill for the heart attack patient. I stress in order to bring out the pathology. It ain't there. He's doing well. Do you think we could start to decrease the Suboxone? I said, I think so. It's only been a week. I'm a little surprised, but you might be in that 10%. Let's try it. So every few days we've been decreasing. Yes?
Do you notice that there are some clinics that may kind of frown upon Suboxone and may suggest not using it, even though you, in your experience, you've noticed that maybe a longer period of time of use may help with that, especially with co-occurring disorders, like I'm thinking of a client who has depression, and they weaned him off of the Suboxone, but he's not driven to really get a job, and he's depressed, so I'm just wondering, what's your experience with that?
Many good questions. You just reminded me of something, though. There are a lot of people who are attending methadone clinics who would like to see if they could do well on Suboxone for whatever period of time, instead of having to attend the clinic every day. And that's greatly frowned upon by the clinic. Why? They'll lose a patient, right? They'll lose a patient. Yeah. No. So they don't want that to happen. In other circumstances where other healthcare professionals have discouraged the use of Suboxone, whenever I have a chance to talk to a person in that position, I discover their ignorance about the medicine. They just don't understand the medicine. They haven't studied it. They don't really know. They don't keep up to date with what we're learning about Suboxone, and so they have a naive opinion. It's interesting what you mentioned about the depression, though, because we know that the opioid system is involved in regulating mood, and so if that's off balance, and it would be if someone were coming off of Suboxone too quickly, then it's not surprising that that person would feel depressed as the expression of that opioid withdrawal. In fact, there are some studies looking at the use of opiates in treatment-resistant depression. Those are the people who don't respond to antidepressants or any other intervention we've tried, and they continue to remain depressed with a very high risk of suicide. And some of them have been shown to respond to the addition of opiates to their antidepressants. It's a fascinating area of study that's just growing every week.
Is there something that you can recommend, reading material that may convince, say, a service that kind of their marching orders is to kind of decrease the Suboxone use and suggest that it's more habit forming?
You're stimulating all kinds of thoughts in me. There are approximately 12,000 substance abuse treatment programs in this country. And there was a great study done about a year ago that included a few hundred of them. Part of the study was to assess knowledge of the treatment providers, knowledge of the up-to-date literature. If you're in the field of providing healthcare treatment, you need to be staying up with what the latest science is so that you're providing the best care we know, right? And certainly as, and I can't stand this term, but I'm going to use it, the consumer, going to your healthcare provider you're just accepting that that healthcare provider knows everything there is to know about the illness that he is treating in you. How naive we all are as consumers. And that was shown to be most true among substance abuse facilities. Now, you all know that Wellbutrin is a medicine that can decrease craving for nicotine, because I taught you that. Wouldn't you expect all healthcare providers in the substance abuse industry to know that fact? Well, the study showed that 60% of treatment providers did not know that. That's scary. They're making decisions about people's lives without knowing the science.
How many are run by doctors?
A handful.
What's the percentage?
Well, I'm glad you asked that question. I don't know if Florida is representative of the rest of the country, but certainly we have the highest concentration of treatment centers in the world, particularly in South Florida. So in the state of Florida, now the last, we looked into this, when was it? Last fall, I think it was September, where Jorge, my assistant, had gathered this data. There were approximately 1,200 treatment facilities in the state of Florida. We had made a claim on our website, on the homepage of our website, that our treatment program was the only one in South Florida, owned and operated by an addiction psychiatrist. And we attempted to be certified by the Better Business Bureau. So they took a look at the website and they said, you can't claim that. And we said, why? They said, because you have to prove it. We don't believe it, first of all. But if it's true, you have to give us the evidence. I said, Jorge, go to it. So in Florida, a substance abuse facility must be licensed by the Department of Children and Families. I said, start there. Get a list from them of every single program in South Florida. He went beyond that. He got a list of every single program in the state of Florida. I said, now, find out from them who the owner is of every single program. Then find out who the medical director is. Find out if the owner has an MD degree. If so, what's the specialty? In addition to all of that, now you're going to cross-reference. Contact the Department of Health in the state of Florida for the names of the doctors, all the doctors. We have access to that. It's public knowledge. Now, the American Psychiatric Association. Contact them, get a list of all of its members, all psychiatrists, all addiction psychiatrists. The American Academy of Addiction Psychiatry. Find out all of the addiction psychiatrists in the state of Florida. I feel like I'm leaving out an organization. I think that was everybody. Now, cross-reference. He called every single one of the programs to confirm that what DCF had was accurate information. All 1,200 programs he called. Of the 1,200 programs, he identified that 20 were owned by physicians. 3 of them were psychiatrists, and 1 was an addiction psychiatrist. Me. It was a pile of information, sent it all to the Better Business Bureau. They gave us their stamp of approval. We are the only program in the state of Florida of 1,200 programs owned and operated by an addiction psychiatrist.
It's kind of sad, actually.
Absolutely. Absolutely.
So the others are owned by, they're just for-profit businesses?
Yes. So of the 1,200, 20 are owned by physicians. That's 1,180 owned by non-physicians. Now, let me just share with you my brief experience working for one of them. I came from New York. My idea of a medical director is that you're the director of treatment. You direct treatment. I'm the physician. These are psychiatric illnesses. I'm supposed to know more than the person who's not the addiction psychiatrist about what the latest state-of-the-art treatment is supposed to be. The executive director understood that from me, and I guess he didn't fully understand what that meant, so he hired me. The first surprise for him and his staff of therapists, some of whom had master's degrees, some had bachelor's degrees. The first surprise was that I expected to evaluate every single patient on admission. He came to me as soon as he heard that I was doing that and said, no, you don't have to do that. Our staff will determine which patients you need to see. You don't have to evaluate them. I said, but in order to do that, they have to do an evaluation. They're essentially saying this person does or does not have a psychiatric illness. Well, this is a treatment facility, so by definition, every patient who walks through the door has a psychiatric illness. So the bachelor's level person is determining whether or not the patient has major depression, and if so, will refer the patient to me. I said, you have to be a psychiatrist to determine whether the patient has a major depression. There the conflict began. They demanded that no patient be on Suboxone at all, ever. That's coming out of complete ignorance. Complete ignorance.
How long did you last?
5 months. 5 months. I wouldn't have lasted a week if it weren't because it was a not-for-profit and run by a board. And so, he was constantly working behind the scenes trying to undermine me with the board, which he knew he needed to do, because the board heard me speak right in the beginning, and they loved me. Wow, bringing state-of-the-art medical treatment to our facility? Wonderful. Little did they know, he didn't want that to happen.
Jessica is my daughter. She, first of all, I've been amazed at how long you've been able to keep her, because we've been through this for a long time. She left Seattle 4.5 years ago. I don't know how many rehabs she's been to, but what's astounded me is the hamster wheel of treatment facilities that seems to run through this industry, that seems to ignorance on the part of the facilities and ignorance on the part of the insurance industry, because they could have saved so much money by treating her for longer like you have. It seems to run the same circle every time. 28 days, cut off the insurance, go to a halfway house with an IOP that overcharges the insurance company, kicks the rent money to the halfway house so they can keep their patients, which results in a lot of free time for these addicts. And what do you do with free time? You fill it by relapsing. And that's what I have seen. And this, back into detox, back into another rehab facility. And so, do you see that same thing? What do you think about it? Because this has been amazing to me and my ex-wife, Carrie. You met Carrie last time, that you have actually been able to keep her this long. And not only that, but just to add the extra in that, so many of these places will not take her when she's on Suboxone. They consider that using.
Right. Many good questions. Yes, we do. We see that over and over again. And what's frustrating for us is that so many of the other facilities make it really difficult for us to be successful with the patient, because the patients become aware very quickly of what the other facilities provide and don't provide. We focus on quality treatment. they focus on going to the beach, providing horses, you know, fluffy pillows, anything they can to get the addict through the door, which works. You know, there are signs in clubhouses where 12-step meetings are run. Come to us. You can keep your cell phone. You know, you all know that we don't allow that. So, the sick patient coming through the door, you don't let me use my cell phone? Treatment down the street does. Bye. We lose so many patients because of those kinds of things. Quality of treatment, least important on their minds. Over and over again. If we were to create a simple spa and we made no demands on you in terms of getting your brain well, we'd be bursting at the beams, through the seams with patients. Now, if those other places didn't exist, then it would be a lot easier for us. If they existed and they provided state-of-the-art quality care, then we would applaud them. Great, good. You know?
It's only a matter of luck, though, sometimes just finding Wellington. You know, when our dog came down, she got referred for somebody else who was willing to say we can't treat you, but people are just tossing out, they're just trying to find help, and it's so
They're
hard.
desperate,
It's a big
yeah.
country. You know, I told you all my friends who just came back with their son from California. And people, it's so hard to find that. And the networking isn't good where you see that this is the best place to go to. It's just, you just really, it's like luck when you find a place. And it does, I mean, it works, but it only works, I mean, it works, you know, like our daughter being back and forth, but still, it's the only place that's known to help her for a long period of time. But, you know, it's like word of mouth now when you hear, you know, spread the word on that. And I'm just so disappointed that we don't have medical professionals running the facilities, because it just actually makes sense that that's the only person that should run the facilities.
You know, I've even spoken with medical directors at the insurance companies because I really blame them. They're authorizing treatment when treatment's not occurring. They're paying for that week long of detox and promoting that the patient go into a rehab after that. I've said to some of the medical directors, you know as well as I do that the literature does not support that. 90% relapse rates. Why are you authorizing a week of detox when you know that is not the recommended treatment? Well, you know, we really don't have anything to do with that. Bye. Not interested.
Isn't it more costly to go long?
Of course it is. Of course it is.
How do you get past the insurance companies, and do you reach out to your policyholder, if, for instance, me, to assist you if there's some difficult pushback, or do you guys just succeed, you know, have a success rate that, you know, because I expect, you know, that they start pushing back at some point.
May I use Robert? Robert came to us with addiction and what initially looked like bipolar disorder now looks a little more like schizoaffective disorder. Initially, the insurance was fine in authorizing PHP. Certainly, we present the clinical information. You know, this is what's going on. This is why he needs this structured level of care. This is the treatment that we're providing. Okay, that continued for a while, and then they were pressuring us to drop the level of care to intensive outpatient. And I wouldn't. Okay, fine, we're not paying for it. All right, we're going to appeal your decision, which is our right. And so each company is forced by the state to have an appeals process in place. And so we went through the hoops, and it's a long, drawn-out process. There's a lot of paperwork involved. You wait for appointments to have telephone conferences. Sometimes it's me speaking with another doctor at that level. Usually it is anyway. And with him, we were able to win the appeal. Continued PHP. Now they're pressuring, drop to IOP again. Go through the same process. Did that a few times until now I agree. He's ready to drop down to IOP. So he drops down to IOP, and time is going by, and he's really struggling, making some progress, but then starting to do worse. Uh-oh, got to take him back to PHP. Because the clinical information was very clear that we provided, the insurance company authorized going back to PHP for a short period of time, and then go through the process again. And now we're back in IOP. Time is going by, he's responding, but very slowly, little by little by little. It takes a long time. Doing all kinds of things with the combinations of medicines. And they keep demanding that we drop to outpatient. And I'm on the phone saying, what are you talking about, outpatient? He'll never take his medicine. He's going to become psychotic. He's going to end up in the hospital. I'm trying to prevent that from happening. So, okay, a little more IOP. This process went on so that we had, I think, accumulated about 4 or 5 months of IOP time when they made a final decision and cut and said, no, outpatient going forward. We said, we don't agree. We went through the appeals process, denied. Next layer, denied. Next layer, denied. We didn't give up. We kept providing the IOP. I was determined. Another 4 or 5 months went by where they had denied care. And we were fighting and getting denials and denials and denials. Finally, okay, now it's our right to demand an external appeal. I love them. Takes it outside of the control of the insurance company. In fact, the insurance company is forced to pay for the evaluation by that reviewer, who I know is a psychiatrist and going to make the decision not based on the insurance company's dollars, but by the clinical need. And we know when we're providing the right care at the right level. We know, so we can't lose. So we presented everything to him. He said, their denial is overturned. You're getting all that 5 months worth of IOP paid. Start all over again. So now, at that point, this was December. He overturned that. They had to pay us for all of those days, 4 or 5 months worth. And then they were forced to provide a little bit of IOP going forward. It was like 5 or 6 days. And then review. We want to drop him to OP. All right, go ahead. I was on the phone with the first medical director after that decision, and I said, don't you know what we went through already? We're just going to go through it again. Save your insurance company some time and money. Don't pay for another external appeal. We're going there. Denied. You can't reason. Actually, I used to get so angry, I'd hang up that phone. I broke so many phones. Now I sit with Dr. Wilms, and she has to sit next to the phone, and I have to be sitting on the other side of the desk.
So there have been some recent changes in law that require insurance companies to treat addiction and mental illness the same as they would treat, say, cancer. Have you noticed any effects from that in the way insurance companies are treating you?
It's gotten worse.
Okay.
Well, they're like a good drug addict. They know how to get around things. They know how to find the loopholes. And they say, oh, we provide the same amount of care in your benefit, but we have to authorize whether it's medically necessary. We'll pay for that heart transplant, but we have to determine whether it's really medically needed. Denied. That's how they get around it. But a beautiful event that just occurred within the last month or so in New York State, which is going to set a precedent. The state attorney's office did a review of Assurant Health insurance company, looking at their number of denials for care in all of medicine versus substance abuse coverage the rate of denial was overwhelmingly greater for substance abuse, proving that there was no parity. They were not treating them equally the way the law mandates. They were fined a tremendous amount of money. It's going to start changing things, you know. Yeah, yeah, yeah. So let me jump ahead because I want you all to get a break. So this was just an example of a study done looking at buprenorphine for 12 months or buprenorphine for 6 days. And one of the effects, certainly, is that the people on buprenorphine stayed in treatment longer. And there's a direct correlation between how long people stay in treatment and getting healthy, staying healthy, decreasing relapse rates. This one, 4 weeks on buprenorphine. Group 1 was tapered over 1 week. Group 2 was tapered over 4 weeks. 85% relapse rate after 3 months. Nowhere in medicine would we accept that, look, I have a couple of different treatment options for you. This one will give you a 85 to 90% relapse rate. This one will give you a 30%, actually 10 to 30% relapse rate. Which one are you going to take? Is there any question in your mind? But this one, tapered over 1 week. By the way, there's not one shred of evidence that that is effective for the majority of people. Yet it is the most commonly practiced way of treating opiate dependence in South Florida. Taper over 1 week. Long-term maintenance, this was the 2 to 5 year study. 90% relapse rate off of buprenorphine, 10% on buprenorphine. Psychotherapy. Many different types of psychotherapy. What is psychotherapy? It's healing the mind using interventions other than medicines. So there are various types of psychotherapy. It's not just talking to somebody, but it's talking to someone in a very structured and now manualized way. Cognitive behavioral therapy, for instance. We know that our emotions are in part regulated by our thoughts. What we think affects the way we feel. So if you're feeling some way you don't want to feel, we look at the thoughts that are going on at the same time and help you to begin to learn to restructure your own thinking. It starts to change the way you're regulating your emotions. Ends up being pretty effective. As a matter of fact, the studies that look at in the treatment of major depression, mild to moderate forms, that cognitive behavioral therapy, when done correctly, is just as effective as any antidepressant medicine. So in addiction, people are learning about how they're regulating their feelings, particularly how the substances are being used in part to help regulate feelings, and what thoughts are involved with that process and gradually changing the thought process, therefore regulating the feelings, obviating the need to take in the substance to do that. Motivation enhancement therapy. When I was in medical school, we were taught the first thing you have to identify in the patient is how motivated he or she is. If he or she is not motivated, don't waste your time. Move on. There's nothing we can do for the unmotivated patient. Now, in the addiction treatment field, you'll hear the naive provider say, well, he's not motivated. Translation of that is, he's not ready. Not ready. Not ready to give up drugs. He wants to still use. What that means, what that tells me, is that they know nothing about motivation enhancement. In fact, there's been a lot of work done over the last 30 years looking at motivation. Motivation, in particular, motivation to change. And the concepts apply to all of us. The various steps that we can take people through who begin by appearing to be unmotivated and talking with them in such a way that you're actually beginning to stimulate a sense of motivation and then you jump on that to magnify the level of motivation. Motivation is something that we can change in people. We don't have to just accept their lack of motivation. That's a symptom of the illness. We don't accept, you have a fever, therefore I can't treat you. That's absurd. My job is to treat the fever. My job is to treat the lack of motivation. Contingency management. Remember that motivation reward system. We do things because they provide a reward. Maybe that reward is a good feeling. Maybe it's more. We work to improve our self-esteem and to earn money so that we can pay our bills, enjoy our families, etc. Right? We're motivated to receive reward. That system, the ventral tegmentum, remember, to the nucleus accumbens, releasing the dopamine, we experience reward. And how that system is hijacked by this process we call addiction. Well, suppose we can hijack it back. Someone comes into treatment. They've been stimulating their reward system with a substance. They come into treatment. They have no more substance. So, what's going to provide reward? I told you a couple of times that after being stimulated so long by the substance, that nucleus accumbens doesn't really experience reward in response to sex, food, water, relationships, the movies, a good steak, right? But a nice thing about the brain that helps the process, just like the skin, if we cut ourselves, we naturally begin to heal. We don't have to do anything, no intervention, just leave it, watch it, it'll heal. It's how our body is made, right? The brain does the same thing. You remove the insult, right? The toxin, the substance. They come in, they're not exposed to the drug anymore. The brain naturally begins to heal. If we did nothing, the brain is healing. And at a rate that is determined by their level of resiliency, right? Keeps coming back to that. Well, they come into treatment now, their reward system wants to respond to something else because there ain't no drug to respond to. The contingency management program is one in which we provide the reward. What do we reward? We reward healthy behaviors. So if a person is exercising significant impulse control problems on admission, then any evidence that the person is able to control the impulse, we reward that. All right. You're able to sit in your seat for 20 minutes without getting up. I'm giving you a reward. Now, we use these dollars, and I didn't name them, someone else did. They're called Moran dollars that we print ourselves, and it has a picture of my ugly face on it. Actually, one of the patients held one up. I told a story a couple months ago. Held one up recently, and I hadn't seen it since, God, it's been a long time. I hadn't seen it. I see the dollars all over the place, but I hadn't looked closely at my picture, and it's been 2 years since we printed them, and I looked at the picture and I said, oh my God, have I aged? So what we're doing, so we give the dollar as soon as we identify the healthy behavior. What the patient is learning, because we try to teach this, but because of the early cognitive deficits on admission, they don't quite get it. We are actually stimulating the release of dopamine in the nucleus accumbens. We're beginning to take over that motivation and reward system again. Doesn't sound like much. Big deal. $1. What are they going to do with the dollar? Well, we have a store where we provide items that they can buy. And most of the items cost $5. So they are earning the dollars one at a time, never more, because getting $2 does not double the effect. That's been proven in the psychological studies. Fascinating. But we want to compound the reward. So they'll get $1 at a time for every healthy behavior. And then when they get 5, they get to reward themselves again. Right? So it has a compounded effect, and gradually, because we're doing this every day, gradually we begin to take over that system. So now they're motivated to make healthy choices, engage in healthy behaviors during the course of the day because they're receiving rewards. That's the contingency management system. Been shown to be very effective. Now, we've made it more complex than it's normally used in clinics, for instance, that use a contingency management program. A common example of it is we will give you a token if you come in from home and your urine drug screen is negative. You earn a token, and then you get to use a number of those tokens to choose a prize that's in a fishbowl or something like that. That's typical. But we want to maximize its use, and that's how we're using it all day, every day. Finally, 12-step facilitation. Why is it part of a program that is based on scientific evidence? Well, now we have research to support the use of the 12-step program in the treatment of addiction. Increasing numbers of studies, looking not only at the effect of participating in a 12-step program, but what the underlying biological mechanism may be. How is participating in a 12-step program affecting the prefrontal cortex, the nucleus accumbens, the orbital frontal cortex, right? How is it helping to regulate mood, tolerate anxiety, exercise judgment? There are lots of studies now looking into these things to understand. We know that a lot of people have benefited from 12-step facilitation, but as scientists, we want to understand mechanisms. How does this work? In the same way, we want to know, how does aspirin work to prevent a heart attack? We need the mechanism. Explain it. We demand the same of something like a 12-step facilitation. And so we help the patients, in fact, demand that they learn all about the 12-step program, and they get a sponsor, they work with the sponsor, they work the 12 steps, how they're making decisions related to promoting a healthy support group, what a healthy support group means, setting a foundation for when they eventually leave us a few years from admission. So, the healthy brain again, PET scan, you see the red is the activity in the limbic system, and then you see somebody methamphetamine who's now 1 month abstinent. Now look, 1 month abstinent. That person went into treatment with methamphetamine dependence. I'm sorry, not that person. That's a healthy person. 1 month after going into treatment has this brain. Now this brain can't function. Look, there's decreased activity in the limbic system. That's going to be poor mood regulation, poor impulse control, poor anxiety tolerance. That person ain't going to stay clean. But that person completed a 30-day program. 14 months abstinent. Improved, almost there, not quite. 14 months. We distinguish between response, remission, and recovery. Response is a decrease in symptoms. I teach the medical students that when we diagnose major depression, we're interested in severity. Is it mild, is it moderate, or is it severe? For a number of different reasons. But there's a scale we use to determine that. It's called the Hamilton Rating Scale. And it's essentially a number of questions that ask about mood, suicidal thoughts, sleep, appetite, energy, concentration, things like that. And depending on what the response is, you receive a score. And then there's an overall score. 0 to 7, there are no symptoms. It's no essential symptoms. It's considered no illness, essentially. From 8 to 16, that's considered mild. 16 to 24, moderate. Above 24 is severe. So suppose you present to your psychiatrist and he performs the Hamilton Rating Scale and has diagnosed major depression, and your score initially is a 30. A response, by definition in psychiatry, is considered a 50% decrease in your symptoms. So if your symptoms improve to the point of bringing that score from a 30 to a 15, you have responded to treatment. But where does that leave you? With a mild to moderate major depression. That's no good. Not good enough anyway. Sure, you've gotten better, but you don't want to settle for response. You want to go into remission, which is a score less than 7. No symptoms. Less than 7. You're in remission. You want all your depressive symptoms gone. And recovery is a more complex concept that we're going to expand upon. The experience, a process, and a sustained status through which individuals, families, and communities impacted by severe alcohol and other drug problems utilize internal and external resources to voluntarily resolve these problems, heal the wounds inflicted by these problems, actively manage their continued vulnerability to such problems, and develop a healthy, productive, and meaningful life. So right off the bat, you see that recovery is way more than just not using drugs. What are the elements? This was based on a survey of people in recovery, in true recovery, and what they thought the elements of recovery were. Of course, no use of drugs or alcohol, so that's abstinence. Most people agreed. By the way, related to that, there are some people, both lay people and some researchers in the field of addiction, who think that for some people, for some patients, that the goal can be to use moderately. There's not significant evidence to support that. Most of us think that might be true of a very rare person because of resiliency, but probably not what we should be shooting for most people suffering from addiction. Essentials: being honest with myself, being able to enjoy life without drinking or using drugs, handling negative feelings without using, changing the way I think through things, not replacing one destructive dependency with another, taking care of my mental health more than I did before, a realistic appraisal of my abilities and my limitations, being able to deal with situations that used to stump me, freedom from feeling physically sick because of my drinking or drug usage, striving to be consistent with my beliefs and values and activities that take up a major part of my time and energy, being able to have relationships where I'm not using people or being used, having people around me who know how to get through life without using, getting along with family or friends better than I did before, trying to live in a place that is not overrun with alcohol or drugs. The enriched recovery, a process of growth and development, taking responsibility for the things I can change, reacting to life's ups and downs in a more balanced way than I used to, living a life that contributes to society, to your family, or to your betterment, having tools to try to feel inner peace when I need to, developing inner strength, improved self-esteem. We're going to come back to growth and development later on, because I want you to understand how for so many people suffering from addiction, it's so very related to their developmental process. That is, that stage that begins in adolescence and develops into adulthood. How that process is thrown off by the disease of addiction. Okay. Spirituality of recovery, very important. Sometimes when people are first learning about the 12-step program, they're turned off by the use of the word God. They don't really understand that God is representing spirituality, and there are ways of helping them to understand that. Being grateful, giving back, helping other people to not use, appreciating I'm part of the universe, something bigger than myself, rather than a very common experience of people suffering from addiction, and that is the universe revolves around me. Becoming more open-minded about spirituality, feeling connected to a spiritual being or force that helps me deal with difficulties in life. Spiritual in nature and has nothing to do with religion, right? Okay. So, just a word about vocational services. We incorporated the need to get a job into our treatment process. Remember, we're treating the brain that's been changed by the compulsive use of a substance, such that now this changed brain is something we say has addiction, right? The orbital frontal cortex, the prefrontal cortex, the ventral tegmentum, the nucleus accumbens, the hippocampus, the amygdala, all these parts of the brain have been changed. As if we were looking at another brain with lesions that we would call a stroke, or another brain with lesions we would call tumors. We look at this brain and we say, oh, that's addiction. Those changes have occurred. So all of the interventions I've been talking about, the psychosocial interventions, the medicines, and the structure of the treatment program, have all been designed in an effort to maximize the likelihood that we will reverse those changes of addiction. I told you how we hijacked that motivation reward system. Now we're teaching it to once again respond to a natural reward. Stimulate this system and secrete a normal amount of dopamine, not bushels full, the way the cocaine does, right? We're changing the brain back to a healthy state. We've discovered that part of that process involves helping people to take responsibility for themselves, be independent of you, have to express a sense of obligation, and most important, provide themselves a healthy way of regulating self-esteem. Ultimately, that drive in the beginning to get high was a way of trying to regulate self-esteem. Think about it. If you feel the way you want to feel, you ain't going to take something that's going to change it. So we have to help them experience new ways of regulating self-esteem. And a major part of that is what you all experience on a daily basis, a sense of accomplishment. I can do this. I am doing this. I'm doing it on my own. Sure, there's a healthy dependency that we all have on each other, but that has to be balanced with the need to be able to take care of myself. And how that, being able to take care of myself, how that supports and regulates my self-esteem. So, as part of the process of treatment, we demand that most people, there are a couple of exceptions, but most people get a job. So, they've responded to treatment in PHP, and we look for the expressions of that, right? We're looking at impulse control and judgment and mood regulation and anxiety tolerance. So as we're seeing the healthy expressions of that, it's telling us, oh, that part of the brain has improved, this part has improved, this part has improved. Right? Now they can tolerate a little bit of stress. We've protected them from it up until this point. Right? In our contained environment in PHP, we're protecting them from stress. Almost completely. We make every choice for them. They experience it initially as, being in jail, being in prison. Oh, this place is worse than prison. I'd rather go back to prison any day. We hear that on a daily basis. I find other ways to support my self-esteem. I know what they're going to look like in a few weeks. Yeah. If we can keep them in long enough. That is the biggest obstacle for us, keeping the patient in treatment. It is so difficult because we're having to work with the diseased brain without being able to physically restrain. If we could physically restrain every patient, we would get everybody well. But we can't touch them. They want to go out the door. We do everything we can to impede them, except touch them. And they insist, and they run. Yeah. But we all recognize, and all of the healthier patients in the community recognize, it's not the person making the choice, it's the disease. It's driving the behavior of that brain. They've all learned that. They know that. They recognize it just as quickly as I do, by the way. So, when they move from PHP into intensive outpatient, we move them into transitional living where they have a little time for the first time on their hands. They have some time in the afternoon to start looking for a job. You know, it may involve learning how to write a resume, how to interview, how to determine what jobs are appropriate. We focus on what we call recovery jobs. We don't want to stress the brain. You know, we've learned that if you were working as a CEO and developed alcohol dependence and come in for treatment, when it comes time to getting a job, you ain't going to get a job working as a CEO. Your brain's not ready. You're going to fall flat on your face. Or you're going to relapse because you won't be able to tolerate the stress. So we talk about recovery jobs. I'll give you an example. I have an assistant medical director. He's out on medical leave. Dr. Scott. He is open about the fact that he has suffered addiction, and he went into treatment, and then he completed treatment, and was expected. He completed the inpatient level of treatment, and when he went into the outpatient level of care, he was expected to get a job. Couldn't work as a doctor. In fact, they recommended that he get a job at Sears selling washers and dryers. And that's what he did for 6 months. It was his recovery job. His brain wasn't ready to take on greater stress. And then eventually, it was. And he went back to practicing as a physician. So we help our patients with that. And we see it as a crucial part of the therapeutic process. And then you'll learn more tomorrow about the whole transitional living and the different levels, and once they get to the highest level, and we're preparing them to move out and live on their own. At that point, that is the end of treatment. If you try to take a shortcut, I'm going to say something and then I'm going to contradict myself. The chances are extremely high that you're just going to fall flat on your face. There ain't no shortcut. This is the process to maximize the likelihood that that brain heals enough so that you can leave here and stay well. This is what does it. Now, it's a complicated and complex process, but it doesn't have to take a long time. I'll give you a beautiful example. We had a patient who was 26, present, transferred from another treatment facility because he was getting hostile and refusing to leave his room during the day, wasn't attending meetings. They thought he was acting strangely, might be talking to himself. Sent him to us. We love those kinds of patients. I diagnosed psychosis, probably schizophrenia, and started on medicine. He was immediately cooperative and willing to do whatever it took. Those words were coming out of his brain within a few days. He responded quickly to the antipsychotic and saw, I need help. He was in a car, his mother was driving the car, they were driving down 95, and he pushed her out of the car. Fortunately, she wasn't hurt. She called the police immediately. He was psychotic. He had these delusional beliefs about where she was driving him. Anyway, that's the presenting clinical picture he had. Agreed to do whatever it took, however long it took, and whatever we said. Music to our ears. So we guided him through the process. Every day, came to group, participated in group, did everything. Moved through PHP very quickly, went into IOP, got a job within a few days, started taking on more hours, got a sponsor right away, attending meetings every single day, worked through the transitional system, level 1, 2, 3, 4. He left with our congratulations and encouragement to go live with a friend, continuing the job and continuing his 12-step program. He did the whole thing in 84 days, start to finish, starting psychotic. Less than 3 months, he did all of that. He did it the right way, and he stayed well. That's the process that we think is the most effective for most people. Now, because of resiliency, maybe some people can take some shortcuts. So, for example, well, I don't want to take more time with examples. You get the point. That's the importance of vocational services. Unfortunately, when they leave our cocoon, they also become exposed to triggers, people, places, and things. Now, remember I told you that in that vulnerable individual, we're almost finished with this, with the addiction lecture, so I want to give you a break, but I need you to just continue with me for a little bit. I know it's exhausting. But think about the help that you're going to be providing your family members. Remember that when you become exposed to the substance and you develop the pleasurable feeling, you're laying down a memory. It's going into that hippocampus, and then that night it's getting transferred to the prefrontal cortex for long-term storage. What happens is as soon as that brain gets exposed to one of these triggers, I remember that, boom, the memory comes alive. Well, the memory is still connected through the neurons, through the neuronal pathways, still connected to that motivation reward system, and in fact, stimulates the release of dopamine into the nucleus accumbens. The relapse process has begun. But it begins before the individual becomes aware of it. It gets expressed in ways that are outside of the awareness initially. What do we see? What does that look like? I've been in treatment long enough. It's time to go back to the town where my mother lives. I'm not going to live with her. I'm going to find a halfway house, but I don't need to be here anymore. I have no intention of using. I'm never going to pick up a drug again. Oh, by the way, that's always a red flag. Never. The person who's healthy in recovery will say, I might, but today I don't want to drink, and I'm going to do everything I can to prevent myself from getting to that vulnerable point, right? But that's how you see it. And they honestly, genuinely do not have a conscious desire to use. But we know what's happening. Something's been triggered. They're already dripping dopamine into the nucleus accumbens. Does that mean it's inevitable? No, because remember I told you that we are constantly bombarded by desires, wishes, cravings from our midbrain that we don't become aware of because the prefrontal cortex puts the brakes on them. Long before I become aware of wanting to have that banana split, the urge was there. If I become aware of it, it was allowed by my prefrontal cortex to come into my awareness. So what if the craving does come into one's awareness? One of our patients, I forget how clean he's been. Oh, by the way, let me tell you a little bit more about him. Opioid dependence. I think more than 20 treatment programs. He's in his mid-20s. Came to us, put him on Suboxone. 24 milligrams. The max is 32 milligrams. People typically need 12 to 16 milligrams. He required 24 milligrams. Went through PHP, got into transitional, was doing beautifully, working with the sponsor, getting a job, responsible. All evidence that his brain was working in a healthy way. Good. Let's start decreasing your Suboxone. This is fantastic. 24 down to 20. Beautiful. Did that for a little while. Did well. Didn't see any evidence. And of course, it's not just my eyes. It's all of the staff, all of the clinical staff, all of the coordinators, and all of the patients are looking out for each other and recognizing, looking for any red flag. They know what to report. They know everybody. We train everybody. They know what an unhealthy behavior looks like. And we jump on it to nip it in the bud. So we're decreasing and decreasing. He's going along fine, doing well. Over the course of many, many months, got him down to 1 milligram. Starts working with the new sponsor. You know, Dylan, you're not clean. That was a stake through his heart. He brought it into community. We talked about it. I asked him permission to call the sponsor and invite him to this lecture. Gave me permission. I called the sponsor. He said, okay, I'll be there. Never showed. But couldn't undo the damage that he had done to Dylan. Dylan didn't tell us. He stopped the Suboxone. It took about a week and a half before he was using heroin again. We were devastated. One of my staff members, we found out where he was. He had been using for about 3 weeks from that point on. 3 weeks before we could find out where he was. And he was staying somewhere. One of our staff members went there and literally picked him up, because he's a little guy, put him into the car and drove him back to us. He learned for himself. He said his sponsor was wrong. He didn't understand. He didn't understand what Suboxone was and how it should be used appropriately. He was at 1 milligram. We would then have gone to 3/4 of a milligram, 1/2 a milligram. If that was too much of a jump, it would have been between 3/4 and 1/2 for a while, until gradually helping the brain to make sure that the brain was able to do it on its own. Delicate process. It's the brain we're talking about. At that level, from 2 milligrams, we didn't go from 2 milligrams to 1 milligram because that's a 50% drop. That's what's important, the relative decrease, not the exact quantity. Anyway, got him, only needed to put him back up to 16 milligrams, not the 24, when he got back to us. Since he had only been using for a few weeks, he really didn't do any significant damage. We were able to get him back on track quickly. And I've been decreasing little by little ever since. So kind of saved him. But there was a reason I went off on that tangent. Triggers. Oh. So he's gotten so well now that he's at level 4 again in transitional, and he just took it upon himself to go visit his family in Alabama. And he said, he handled it well. Things were going well. He handled the relationship with his mother and his sisters well. But he said, I said, did you experience any craving along the way? He said, one time at the airport. He said, in the past, I've always used at airports. And I walked into the airport, I started feeling a desire, and I got on the phone right away. Called a support. He said, help me. But what it helped him to do, biologically, and now you can understand this, is actually stimulate his prefrontal cortex at that moment, which made it a little stronger so that it could work through the orbital frontal cortex and inhibit that craving. So he snuffed it out. That's a healthy brain. So, you see someone with years of recovery, they're doing that automatically on a daily basis. They're getting triggered left and right, but it doesn't even come into their sense of awareness because their healthy prefrontal cortex is just snuffing that out. I'll give you another example of that. The psychoanalysts think, and there's lots of evidence to support this, I think, that we all have basic drives, sex and aggression. Sex and aggression. And everything else are derivatives of those basic drives. Now, you know when you're sexually turned on, right? So there are times, for most of us, it's not 24 hours a day. On a deeper level, it's 24 hours a day, but because of our healthy prefrontal cortices, it keeps most of that inhibited, out of our awareness. Someone says something that irritates us. The irritation is something that we're allowing ourselves to experience. On a deeper level, it's aggression to the point of wanting to kill the person. But we're more sophisticated beings. Our prefrontal cortex has evolved in such a way that it inhibits 99.9% of that desire to kill and allows just that 0.1% which we experience as irritability. You see? So it's the same system, is my point, that we develop all sorts of unacceptable impulses that don't come into our awareness because our brain is keeping them suppressed. And that's what's happening in the healthy addict's mind. The triggers are always there. They're constantly surrounded out there in society, but they don't become aware of them. And their brain is able to suppress them in such a way that they're not dictating behavior. Yes?
I was reading an article a couple of weeks ago about memory. I can't remember who was doing the study. I think it was Stanford, but it was they were able to target memories in mice, have them recall a pleasurable memory and destroy the memory and break it up so that they no longer have it. And they were talking about wanting to do this with addicts with addiction. And obviously there's no approval for that yet. I was just wondering if you thought that was something on the horizon, or obviously there's a lot of other implications of destroying ill memories, but that
Right,
seemed to be
right.
the first thing that they were wanting to use it for.
That's interesting. I haven't seen anything about
It's
it.
in the New York Times 2 weeks ago on Sunday, the Sunday paper.
I read the Sunday paper. I missed it. Fascinating, though. So, relapse is the rule rather than the exception, I suppose. Doesn't mean that it's inevitable and that it has to happen in everybody, but it does happen commonly. A common experience for us is that someone will come in, they're starting to do well, they leave prematurely, relapse, and then come back. It's as if, they have this false sense that they're healthy because they feel so much better. And they think that they can handle it, not intending to use. And they go out and they realize how vulnerable they really were. And then that becomes a whole new learning experience that makes them even stronger in recovery. So it's not always a bad thing. It's a risky way to do it. But not only do we see it here commonly, but I got a text message from one of our former patients, and some of the family members have been in former community meetings with her, and she texted me today. She left and she relapsed. And then she went back into treatment, but because of legal reasons, she had to stay in her home state. They wouldn't allow her to come back here. And she texted me to let me know how well she's been doing ever since that brief relapse after leaving us. It helped her to recognize her vulnerability and how she had to work even harder. And she did, and now she's working a job, she's living in a halfway house, and she feels proud of her abstinence. It's really great to hear. And we see that a lot when we're checking in with people who have left prematurely to see what's become of them. Often we hear that when they left us, they briefly relapsed and then stopped. Some have gone into other treatment programs, many have not, and they have remained sober ever since. But it was like they had to teach themselves. They can't use. And also, the experience of using isn't pleasurable. I don't want to feel like this kind of response is what we often hear. So people end up doing well. Now, I did share that. I wasn't sure if I should, with the community, with the PHP community, that in fact, when we looked at the statistics, the last time we looked at it, which was about a year and a half ago, the vast majority of people who left prematurely have done well. Of course, we don't want to encourage the people in PHP to say, okay, I'm going to leave prematurely. Yes. Oh, sorry.
And you can answer it later, I just didn't want to forget it. We're talking so much about abstaining. What do you do in like my situation where I want him medically compliant? I want to tell him to take these drugs, and you're in a 12-step. How do you distinguish the two? The correct medicine and the drug that you should never take?
Oh, they're learning. That's a simple concept, actually, for most of the patients. Yeah, yeah.
Because I could never keep him medically compliant. So.
Right. Now, you'll learn in the next lecture about insight. And insight, we're starting to learn, is subserved by a combination of certain parts of the brain. Now, some of these illnesses also impair those same parts of the brain, so that somebody with bipolar disorder, for example, the part of the brain responsible for insight is impaired. So you can tell them that they're manic until the cows come home. They're not going to believe you. There's nothing wrong with me. You're manic. I'm not manic, right? Because that part of the brain that gives them a sense of awareness, self-awareness, is impaired at the moment. That's the thing that normally drives lack of adherence to medicines that are prescribed. Yeah. I'm going to skip over this video. It was someone who had given, a former patient who had given permission to us to show it. She talks very eloquently about what she experienced in addiction and then in treatment, and that what seemed to drive her relapse and what that relapse was all about. It's rather long, and I know you must all be exhausted, and I want to get you to a break. And just to point out that addiction is a chronic illness like many other chronic illnesses, hypertension, asthma, diabetes, and it's about a 50% relapse rate. This is the difficult comparisons because of the length of time that people are studied. Obviously, they're going to be higher rates of relapse over 10 years than over the first month out of treatment, for example. There are many variables, but those same variables apply to all of the chronic illnesses. Relapse doesn't mean failure. Chronic diseases require maintenance treatment. So the goal usually is to help an individual learn enough about his illness of addiction, how he or she, or another way of saying it is how his brain has been affected by that disease, what his limitations are, what puts him at risk for relapse, and strengthening himself in such a way that when he becomes exposed to those risk factors, he is optimally going to manage them and prevent the risk of relapse. So that's what they are expected to learn in the process of treatment. And I think that's it. This is someone who suffered from stimulant dependence, cocaine, methamphetamine, mostly, for a few years, and was actually psychotic continually, untreated, for 2 years. And she can tell you a lot of stories. She wasn't one of our patients, but she did come to me a few years after she got into treatment, and now she's on our staff. That's Jill. You'll see her this weekend. She's our director of cognitive enhancement now, and I'm proud of her, and she has a lot that she teaches to all of our patients, actually. She works a very strong recovery program. And in fact, I think tomorrow at the end of the day is the Al-Anon meeting, and she and her mother facilitate that meeting. So why don't we take a 10-minute break, and then I'll teach you everything else you need to learn about psychiatry.